Hello and welcome to today's VJHemOnc podcast, where we will be focusing on the management of chronic lymphocytic leukemia in resource-limited settings. Despite advances in targeted therapies, many patients around the world face barriers to optimal care. In this episode, we'll discuss the development of resource-restricted recommendations for the diagnosis and management of CLL, ongoing projects including work by the Max Foundation, and the 6 principles of excellence that healthcare professionals and patient advocacy organizations should be aware of when caring for patients with CLL. This episode is part of the CLL channel on VJHemOnc, which is supported by AbbVie, B1 Medicines, and Lilly. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. So, let's go to our first speaker, Mazyar Shadman, who provides insight into the development of resource-restricted recommendations.
So during the iwCLL meeting, we are happy to announce that the working group at the iwCLL on resource-restricted guidelines is going to start working after the approval of the board of the iwCLL. So the idea is we're working on 2 different projects. First, we realized that there are a number of diagnostic and therapeutic options for CLL, but unfortunately, these options are now limited to certain areas of the world and some specific countries. So when it comes to many of the countries where CLL patients are still in need of diagnostic and therapeutic options, those options are either unavailable, or if they're available, our colleagues only have access to a limited number of these treatments. So this means that the guidelines that we use, for example, in US, in UK, Australia, or Europe, are not applicable to our colleagues who practice in those settings, because we write those guidelines assuming that there is full access to these agents and the diagnostic tests. So the idea here for the resource-focused guidelines, or I should say recommendations and not guidelines, is to define different tiers of access and then try to provide recommendations in how to utilize different treatment options or diagnostic options depending on what level of access is available in each area. So the idea is to have colleagues from those areas actually have the major role in writing those recommendations. And of course, this will be a teamwork that, we'll have a combination of colleagues from more, from countries with more access to those agents joining. But really the expectation and our goal is to have really the colleagues who practice in those settings really drive the main kind of message and the recommendation that will come out of this. So this is our first project. This is again focused on providers and physicians or colleagues who work on diagnostics and CLL. There's a second effort that we'll also start working on, and that's providing guidance on how to use resources. And this is mainly for, let's say, healthcare authorities and, people who are at the decision-making level. And the idea is that we would like to have a priority list. So if there is limited resource, how's the best way of using it for CLL, either for diagnostic purposes or for therapeutic purposes? So there is a lot of work that will be done to define what would be the number 1 or number 2 diagnostic or prognostic test that we would need to have in order to provide the best care for CLL patients. And also, if we have limited resources and we have, let's say, the possibility of bringing 1 or 2 drugs to country or to the area that we have the health, basically authority, what are the different characteristics of those treatment options? And then they can make the decision in terms of having the treatment available that would benefit most patients. So these are 2 important efforts, and I'm very happy that the board has approved these efforts, and we will have a presentation at the meeting to basically let everybody know that we will start working on those 2 important projects. On top of that, we will also announce an important survey that we will be soon distributing to hopefully all countries. And the idea is to have an understanding of what is the level of access to, again, diagnostic, prognostic markers, and also therapeutic options. And that will hopefully give us a good understanding of the current benchmark. And, with all that, the idea is to hopefully give the message out that access is limited, and hopefully in future we can make it better. And maybe in future meetings, we can have another report showing that our access has improved. But I think it's important to have that voice heard. And we believe that by generating that data, we will be able to show it in a form of a presentation and hopefully publication that there is a critical need for improving access to all these great options that we have for CLL patients.
Next, Anna Schuh, Andrielle Yost and Catherina Scheepers will speak about ongoing projects to improve access to treatment and outcomes for patients with CLL, including work by iwCLL and the Max Foundation.
The iwCLL strategically decided a few years ago now that they really want to expand their outreach globally, especially to resource-restricted countries, low-middle-income countries. And we as part of the Global Partnership Subcommittee, we are employing a multi-pronged approach to this. So first of all, we have an emphasis on training and education. So we offer visiting fellowships. We offer capacity building programs. We have travel awards for the biannual meeting of the iwCLL. We have an online education program that consists of recorded lectures and live master courses that are shared by board members of the iwCLL. And it's specifically for people who are looking after patients with CLL in low middle income settings. It's completely for free, and everybody gets a certificate of attendance at the end. And that's really been very successful, and the uptake, we have students from all continents, and it accompanies the access program of the Max Foundation. So the iwCLL partnered with the Max Foundation in providing and distributing BTK inhibitors. At the moment, it's one of them called zanubrutinib. And this drug is now being distributed hopefully to many low middle income countries. It would be really great if other companies would also follow B1's excellent example of providing access to some of their drugs, because the issue of copycats and drugs that are being sold in many countries where the regulatory authorities are not do not reinforce the access so much and control access. Copycats are a real problem. And we need to ensure that the right drug is coming to the right patient at the right time. And the Max Foundation has a 25 years experience of delivering life-saving drugs in both chronic myeloid leukemia and now also in many solid tumors to patients in need. And we really want to support this program. So the education around diagnosis of CLL, what are the side effects of the drugs, how do we monitor treatment response, this education is really important, and this is what the iwCLL provides. So the most recent initiatives of the Global Partnership Subcommittees are that we also want to strengthen the development of resource-restricted recommendations. So we had a lot of requests from our clinical colleagues in low-middle-income countries, but also actually in other parts of the world where some patients can afford anything and other patients can't afford anything. So we need increasingly develop recommendations around what is really essential, what do we really need to establish the diagnosis, what are the minimal criteria, and also what are the really important therapies. And the treatment algorithms can be adapted to some extent according to how much patients can afford. And so we want to play a role as the iwCLL in defining resource-restricted recommendations. So we have a working party working on this, and then we have another working party working on really beginning to create some form of capacity building in clinical research and translational research, because ultimately we want those countries also to run clinical studies, in particular in ethnically diverse parts of the world, where it's important that we run at least bioequivalent studies, or we're running real-world studies. So we have partnered with ERIC to utilize and distribute a database that can be used for data collection. Initially, maybe to obtain very basic demographic data. In many countries, we don't even know how many patients are there with CLL, what type of CLL do they get, what are their their risk factors, how old are they. So it's very basic information. But then increasingly, we would want to collect data on side effects of drugs, response duration of drugs. And the way this, or the only way this will actually work, even across Europe and the US, would be in ways of federated databases. So we are working off the same data sheets, so we're collecting the same data, but then each country can do their individual analysis. And that means that there's no issues with confidentiality or access to confidential data in any shape or form, because we are only sharing the secondary analysis and confirming each other's analysis. So we hope that this will be an exciting project for upcoming leaders, future leaders in research in those countries.
So the Max Foundation is a global health organization, and we work in low middle income countries to facilitate access to treatment. We are on a mission to accelerate this access because, as we know, patients in these countries often don't have access to the treatments they need. And even where it's available, it's not accessible. So we started the CLL program 2 years ago through the help of B1 that was so kind to give us an investment of treatment so that we could start building the health system in preparation for treating more CLL patients in Ethiopia. To date, we have close to 100 patients receiving treatment, and this would not have been possible up to date if it wasn't for this investment. There are so many barriers. We would need a whole day to talk about it. But the initial barrier that most patients face is lack of access to treatment. Without the treatment, there isn't a need for impetus to develop diagnostics, to train physicians, to actually educate patients about what is available. So what we often find, and that has really been proven through our model, is that treatment is the catalyst that comes into a country and then lets the rest of the slots fall in place. I think CLL, as we know, is really not just centralized. It is really a global condition that affects so many patients out there. We've seen such great development in treatment, and there is so much out there and available, but we still need that innovation to come to these low middle income countries. We are creating a gap in equity for patients where we see the treatment is accelerate in some areas where the rest of us still will have to catch up.
At the Max Foundation, we're really driven by a simple ethos, which is that access to medicine is a human right. And so for 25 years, we've been providing treatment access to patients in low and middle income countries. So we started with CML 25 years ago. And in 2023, we're able to launch a treatment access program for CLL. And so to implement this program, we have been assessing the institutional capacity of institutions and physicians that we've worked with for 2 decades. And in this assessment, we're trying to understand the readiness to implement a treatment access program for a targeted therapy for CLL. And so what we're seeing is really that diagnostic capacity can be quite limited in these countries. Access to targeted therapies are completely unavailable. If they are, they're outrageously expensive. Patients are unable to afford them. And the holistic experience of what patients in high-income countries can receive when they are facing CLL can be quite different in these low-income settings. In 2023, we signed an agreement with a biotech company to make the second-generation BTKI zanubrutinib available to patients in up to 29 countries. And we're a deeply collaborative organization. So to implement this program, it inherently requires collaboration with our in-country partner institutions, in-country physicians, global experts, such as the iwCLL for training of these physicians, and our in-country team. And so since that time in 2023, we have supported a total of 270 patients, and we're currently supporting 250 patients. And this is across 3 countries, Armenia, Ethiopia, and Nepal. And we've been able to provide training to 5 physicians from these 3 countries through our relationship with the iwCLL. And so what we are seeing is that patients are doing really well, responding well to zanubrutinib. Many are able to return to their jobs, which they have had to leave months or years ago, and they're able to live their full lives again, which is ultimately why we do this work. We see within the CLL program, similarly to our CML program, that the incidence is at a younger age group. So the median age at diagnosis for patients in our program is 63, which is nearly 10 years younger than what the global average is for CLL in the high income setting. as part of the implementation of our CLL program, outside of the 3 countries where we are currently delivering this treatment access program, we completed a capacity assessment in 18 countries and 21 institutions. And so this was to assess the readiness of each site to be able to diagnose and treat patients with CLL. And so through this assessment, what we have found is that there's a really strong readiness to deliver targeted therapy for CLL, such as the second generation BTKIs or BCL2 inhibitors. Much of these countries do not have access to any targeted therapy, as I mentioned. And so through this assessment, we know that there's a strong diagnostic capacity in terms of flow cytometry and what's required in order for a patient to start treatment. Prognostic markers can be a challenge, but many countries are able to obtain these results from sourcing the tests from out-of-country sources. And there's a strong clinical management that's already occurring for CLL patients, but access to the therapy is so critical. And so we are only limited right now in terms of our ability to expand the program based on where things currently stand with our partnership with the biotech company. But we encourage any other companies that are interested to see sizable impact in these settings to partner with us, and we would love to just continue this work together.
Finally, we go to Brian Koffman, who outlines the 6 principles for excellence that healthcare professionals and patient advocacy organizations should be aware of when caring for patients with CLL. These aim to promote improved care for CLL patients worldwide, including in lower and middle-income countries where access to resources may be limited.
I was involved in an international effort to look at what were the basic rights patients had. And this went beyond just looking at high-income first world countries, but looking at lower and middle-income countries too. And with the help of patient advocates from around the world and from every continent, we came up with 6 principles that we were able to publish and are trying to disseminate for patients and patient advocates and healthcare professionals to use when they approach their CLL patients. And the first one seems pretty basic for people in a first world country, is that patients receive an accurate and definitive diagnosis. But that's not taken for granted in many countries where access to appropriate flow cytometry and other testing is just not available. The second is that the patients deserve to have high quality information, to be informed of what's been going on with them, and it should be informed in patient-friendly language. The third, and again, this is going to vary from country to country and resource to resource, but all decisions, treatment-related especially, should be shared medical decision-making. The fourth is patients should have access to affordable, effective care and should have a range of specialists available to them to take care of the CLL. Most patients are going to live very long lives with their CLL, and most patients are going to go through multiple therapies because all therapies are essentially palliative. So understanding that and working with the patient and having access to the appropriate specialists is going to be critical. The fifth principle is emotional and psychological support. Because it's an incurable and long-duration disease, it's important that there be a bond between the healthcare provider and the patient in front of them, that they can work together and understand the anxieties patients go through with the diagnosis, with the beginning of therapies, with the ending of therapies. And the final is that holistic piece, that a patient deserves a care model that recognizes the total impact of CLL on them, on all their systems, all their physical, emotional, psychosocial systems. And that is something we strive to do and should be strived, whatever the circumstances are, in whatever environment you're treating the patients.
That's all the updates we have for you today. We hope you enjoyed. Be sure to follow us on X at VJHemOnc and subscribe to our podcasts on Spotify, Apple, or Podbean. And head over to VJHemOnc.com to see our full coverage from the iwCLL meeting 2025. Until next time.